Hello, Dr. Shiva K. Misra, the past president of Associations of Surgeons of India. And we are going to talk about for the next half an hour surgical update and COVID-19. When I say COVID-19, we are in a situation all routine surgeries has been postponed. And yesterday we saw a patient in Wokad in Mumbai, where 8th day of a cardiology admission, he was found to be positive for COVID, and the whole hospital has been shut down. Shiva, I think the time has come for us to know that every patient is COVID positive unless proved otherwise.
Yes.
And maybe times to come, we may ask, like in HIV, we may ask that a COVID test to be done in every patient before a surgery is taken. Ladies and gentlemen, and dear colleague, I present to you Dr. Shiva K. Misra.
Namaskar. I bring greetings from the Central Council of Health and Family Welfare and the National Board of Examinations and the Association of Surgeons of India to all of you. And I'm especially thankful to Dr. Agarwal and the Heart Care Foundation and MedTalks for organizing this digital conference, which will be of immense help to the medical professionals as well as specialists across the country, not only across the country, but maybe across the globe when we are facing this COVID-19 pandemic. My topic today is surgery update and COVID-19. And as we all know that this outbreak continues to challenge our nation, the expert projections estimate that despite social distancing being practiced very rigorously in our country, we have yet to feel the full impact of COVID-19. And we, as surgeons, need to help prepare locally for the potential increase in COVID-19 patients. And we need to follow 7 basics while managing COVID-19 in surgical system. And these are: you prepare for a rapidly evolving situation. Situation is changing every day. Postpone elective operations immediately. Develop a clear plan for providing essential operations during the pandemic. Educate all your surgical staff on personal protective equipment and COVID-19 management. Decrease exposure of healthcare staff and develop a dedicated COVID-19 operating space in your surgical department. The changing landscape of pandemic may require patient transfers and repurposing operation theaters to support critical care patients in time to come. And we must rationalize how we are going to face this crisis. We must rationalize our services, and the foremost and most important is routine OPD work should be kept to minimum. No relative should be allowed unless it is very, very necessary. Social distancing must be practiced within the clinic and the hospitals, and all patients with respiratory symptoms should be made to wear paper masks in the waiting area and instructed on cough and sneeze hygiene. And doctor's clinic inside the chamber also, this should be well ventilated, and patient should be sitting at least 6 feet away from your chair where you are sitting. And doctor should wear a surgical mask and scrub hands with soap and water as and when and as many times he has got interaction with the patient. Then you must postpone all elective surgical and endoscopic procedures. And this surgery should be offered or limited to those whose needs are eminently life-threatening. These decisions should be based on COVID-19 burden as well as on medical, logistical, and organizational considerations. For example, if the malignancy is there and it could progress and lead to death, if not operated in time, then you have to operate. Or there is some acute perforation of the bowel, or there is a bleeding inside, or road traffic accident, you have to operate them immediately. All other cases should be delayed until after the peak of the pandemic. This will minimize the risk to both patients as well as healthcare team, and will also preserve necessary resources like beds, ventilator, and personal protective equipments for the time to come and where they are needed most. So, and another important thing is just send your non-essential hospital staff or the office staff on leave. They should work from home or they should take rest. Only bare minimum number of staff which is necessary to assist you in operation or to provide help during rounds and other encounters. All in-person educational sessions, counseling should be stopped or cancelled. In-person surgical consultation should be performed only when it is mandatory or necessary. Just go back. Yeah. So that is when necessary. And the coming to very important part of my talk, that how to protect the protectors. It is very, very important because healthcare workers cannot be manufactured urgently or run at 100% occupancy for long period. So we must see that they are not harmed. The healthcare workers should not be deployed as pawns to combat COVID-19, but as human individuals. COVID-19 has spread at an exponential rate in several countries, significantly impacting many lives and affecting our practice as healthcare professionals. So these recommendations which I'm going to suggest, they are based on best available evidence and expert opinion from global surgical community. One has to reinforce standard hygiene practices. And I'm sorry to say that 50% of surgical teams do not follow the standard hygiene practices. And 35% of healthcare facilities in low and middle income countries do not have even soap and water for hand hygiene. This is the situation. So we must emphasize, especially on doctors and healthcare workers, about the pivotal importance of adequate hand and respiratory hygiene practices. Alcohol-based hand rub when hands are not visibly soiled, and if soiled, then soap and water used for at least 20 seconds will sanitize your hand. Visual alerts must be placed within your clinic and the hospitals about the standard hygiene practices. If you wear a mask, the impact of corona can be stopped or reduced by 68%. Similarly, washing hands at least 10 times daily will reduce the incidence or chances of corona infection by 55%. Similarly, wearing gloves will also offer the similar kind of benefit. So, if you combine all the measures like hand washing, mask, gloves, and protective gown, that will give an immunity of up to 91%, which is quite good and impressive. Then what are the practical measures which I think every surgeon or surgical team should take while doing surgery? One most important is that consent should be taken now for risk of COVID-19 exposure from every patient. This is important. Then, as Dr. Agarwal was talking, the pre-operative testing of COVID-19, as we used to do for HIV, HCV, and HBsAg, etc. If it is available, then COVID-19 testing should be done. Intubation and extubation should take place within a negative pressure room or well-ventilated room, because these are aerosol generating procedures. Then OT should be appropriately filtered and ventilated, and only essential staff should be there inside the OT, and that too, they should not be allowed to go out. No exchange should be permitted during the surgery. And all members of the OT staff should wear personal protective equipments. The electrosurgery units should be set to the lowest possible setting, and that too, they should be used with a smoke suction so that there is no aerosolization in the operation theater. The surgical equipments which are used for the patient, suspected COVID-19 patient, or you can say you should suspect now, they should be cleaned separately. placement and removal of personal protective equipments should be done according to CDC guidelines. And whatever practical measures I am suggesting, these measures should be used in all surgical procedures during the pandemic, regardless of COVID status. And this is just a summary what I have said right now, right from personal protection, minimum number of theater staff, then service rationalization, keeping minimum bare staff in the hospital, postponing all the elective cases, no face-to-face consultation, only video consultation, then minimum use of laparoscopy, although it has not been proved that COVID-19 risk is increased in laparoscopy, but because of this CO2 gas release, which may cause again a spread of the coronavirus, so it should be used with caution, using device with filter to stop or to prevent all those coronavirus spread. Then always use minimum of electrocautery, and that too with a suction. Take consent for corona risks, and also try to do in every case now, as the number of corona positive cases are increasing. So every person is suspected corona positive, and we should do a testing. If operation is mandatory, then a pre-operative testing for corona. And then we should avoid endoscopy, or when doing endoscopy, all staff should wear personal protective equipment, and we should have a dedicated operation room for COVID-19 as far as possible. Then a word about personal protective equipment. I'm not going to detail, but I'm saying this is of key concern in every country, including the developed countries like US and UK. There is a acute shortage of personal protective equipments, and this goes manifold in developing countries. And unfortunately, because of this, many physicians are forced to put themselves at risk and are already managing these patients using inadequate equipments, and thus exposing themselves to COVID-19 infection. Now, I'm going to address 4 key areas about the surgery and how one should do. A creation of surgical review committee, number 1. Then elective case triage guidelines for surgical care. Elective case triage guidelines for surgical care in specific situations. And most important would be how to optimize protection for surgeon before, during, and after surgery. Surgical review. Why surgical review committee is required? Because it is composed of surgeon, anesthetist, as well as nursing personnel, and this committee will only decide that which patient really need a urgent surgery, where surgery cannot be deferred. So it is essential this committee will provide transparent and responsive oversight, and it will also decide about patient's priority level of need of surgery. But they should be meeting mostly virtually, as we are meeting today. So not in person, but they can contact and they can discuss about the patient and all the precautions which are needed to be taken. Then elective case triage guidelines for surgical care. Sorry, I have to go back a bit. As we all know as a surgeon that laparoscopy is the method, or is the way where most of the surgery are done across the world, across the globe. So, and there is hardly any evidence regarding COVID-19 that it will put additional risk to the patient as compared to the open surgery. But one should be careful. One should err towards this side that yes, this could be potentially harmful. So incision for the port should be made as small as possible so as to introduce the port. There should not be any leakage around the port. Then CO2 insufflation pressure should also be kept to the minimum, and all pneumoperitoneum should be safely evacuated either through a filtration system before closure, trocar removal, or specimen extraction or conversion to open, rather than if it is goes like that, it will create a lot of vapors, lot of this impact, and the coronavirus can be distributed into the air. So one should avoid while doing, or one should take precaution while doing laparoscopy. And this is an important slide which shows our level of preparedness, maximizing the calm before a storm. We have seen very gradual increase of COVID-19 cases in our country, and by and large we have been successful, but you never know what is going to happen in a week's time now. So from the point of alert where no patient, to level 2, first patient with COVID-19, and then level 1, we are scared about condition 0 where it is overflowing COVID-19 patients. So from this place to this place, we have to watch, we have to get ourselves prepared. So there should be calm. We should not do other activities. We should focus on COVID-19 infected patients. And what is the principle is that do not lose hope, preserve purpose, maintain a sense of community, communicate clearly and concisely, and be flexible. So this is how we should proceed. Now, overarching principle for all cases: the patient should receive appropriate and timely surgical care. As a surgeon, as a surgical department, we are responsible to provide appropriate and timely surgical care. But consider non-operative management whenever it is clinically appropriate. Consider waiting on results of COVID-19 testing in patients who may be infected. Avoid emergency surgical procedures at night due to limited team staffing. So whenever it is mandatory, try to avoid night. Then coming to specific situations like breast cancer surgery, colorectal cancer, metabolic surgery, and emergency general surgery. But for the first three, I would say their respective departments, which consist of surgeon, oncologist, radiologist, nurses, anesthetists. So they should have that board, tumor board, or again a review committee, which should decide which patient really needs an urgent operation. And according to the decision of the board, it should not be one-man decision. The decision of the board, the surgeries should be taken with full precaution, with all PPE in place. For emergency general surgery, general recommendations are that the case status determination, that is risk of death time frame, should be made by a multidisciplinary team, ideally in a multi-clinician setting, that is called breast tumor board conference. This multidisciplinary discussion should be documented in the medical record. So why the decision of operating or not operating has been done, what alternative treatment is being provided without doing much harm to the patient. The emergency general surgery guiding principles are to provide timely surgical care while optimizing patient care resources, no substitute for sound surgical judgment. And if the medical management fails, which is the priority given in the COVID-19 infection time, then you have got no other option but to operate. Operate also if their delay will lead to prolonged hospital stay or readmission, or it will harm the patient. In these situations, you should operate the patient. The conditions like pneumoperitoneum, intestinal ischemia, intestinal obstruction, well, they call for emergent surgery, but non-operative management can be offered to the obstruction, small bowel obstruction, secondary to adhesions. For appendicitis, uncomplicated, you can manage it with antibiotics and IV fluids. But if there is a fecolith, appendicolith, or the disease has progressed beyond right lower quadrant, then this treatment is not going to succeed. and a short stay or outpatient lap appendectomy should be done. And in complicated means where the already appendix has burst open or peritonitis has occurred, you don't have a choice but to operate. Similarly, in symptomatic cholelithiasis, if pain is there, manage pain. Don't go for any surgery. Surgery can be delayed. But if the pain is not going or refractory to the medical management, then lap cholecystectomy is the option. Similarly, choledocholithiasis. If it is without cholangitis, you can have medical management or expectant management. But if the cholangitis is there, then ERCP with sphincterotomy is with all appropriate precaution, because again it causes harm with the fumes, and it should be avoided. So this is how one should see the specific operative risks are. You have to see that minimum number of personnel stay within the operation theater. There should not be any visitor. There should be a smoke evacuator, and also try to avoid laparoscopy and also wear personal protective equipments. Then for the surgeon protection before and after separating from the patient, it is very important. Surgeon comes to the operation theater, so he should wear scrub clothes after arriving to the hospital, and after separating from the patient, remove the scrub clothes, shower before changing into the clean scrub suit and or wearing a home clothes, and wash the hands frequently and maintain safe social distancing. This is very, very important. Then this picture depicts how one should be caring about himself as well as the family, keeping a distance. That distance is to be maintained, and if somebody is working regularly in that atmosphere, it is better to avoid home, and they should stay in separate hotels, as the government has made in the various hospitals arrangements to stay in the host hotel in the isolation as they are dealing with the COVID-19 patients. So just before concluding, this is the slide that courage is not a matter of not being frightened, it's being afraid and doing what you have to do anyway. And as we have all seen, the country stands together. Together we stand, together we fight, together we will win. Thanks to Corona warriors. Thank you so much.
Dr. Shiva, thank you very much for being here. I'd like to summarize that in this COVID era, we must postpone our surgeries,
yes,
which can wait. But emergency surgeries needs to be taken.
Yeah.
And every patient needs to be COVID positive unless proved otherwise.
Very true, very true, very true. That is I think message. Yeah.
Message is only one, and then this COVID will teach us examples, and with this COVID we should be able to reduce hospital acquired infections in the country. The reason being we will be more careful, and that COVID will teach us more practices and which will reduce hospital acquired infections in future. So every adversity is an opportunity. Look for this opportunity. Thank you very much, Shiva, to be here with us. And that was Dr. Shiva K. Misra, the past president of Association of Surgeons of India. Thank you very much.
Thank you.